Hello everybody. My name is Professor Zena and I am Professor of Nursing and Head of the School of Nursing and Midwifery at the Royal College of Surgeons in Ireland. And it's my great pleasure to record this webinar for you, and the title of it is Placing the Problem of Pressure Ulcers in Ireland into Context, Focusing on Risk Assessment. So what we're going to talk about is in two parts. So part A, we're going to really look around pressure ulcer epidemiology in Ireland. We'll talk about the human costs of pressure ulcers, the financial impact of pressure ulcers, talk a little bit about regulation requirements and why pressure ulcers are important for us in this regard, and talk some more about patient safety. So we need to start by understanding what the definition of a pressure ulcer is, because really, if you're able to understand that, then prevention should really come into place for you much more readily than it would be if you start to think about all of the potential possibilities around pressure ulcers. So the National Pressure Ulcer Advisory Panel and the European Pressure Ulcer Advisory Panel and the Pan-Pacific Pressure Injury Alliance developed their guidelines in 2009 and updated them in 2014. And you can access these guidelines on the European Pressure Ulcer Advisory Panel website, and you'll be specifically accessing the quick reference guide. And so they define a pressure ulcer as a localized injury to the skin and/or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. They continue to say that there are a number of contributing or confounding factors that are also associated with pressure ulcers, but the significance of these have yet to be elucidated. So if you look closely at the definition, it's saying to you that a pressure ulcer is a localized injury to the skin and/or underlying tissue, and it happens because of pressure or pressure in combination with shear. So when we're thinking about it, this is what we're looking at. So you might be well familiar with somebody when you turn them over in bed, you examine their skin, you see this area of redness that doesn't go away when you press on it, and we consider that to be a stage 1 pressure ulcer. And here you have where there's like a broken area of skin, a blister or an abrasion, and we call this a stage 2. And you can see from the picture here that this particular one has been caused by the individual directly lying on their catheter. Here we have stage 3, which is a cavity wound which does not extend to muscle or bone, and then stage 4, which extends right down to muscle or bone. So in essence, these are the wounds that we are trying to avoid. So from an Irish perspective, there are 9 published studies that have explored pressure ulcer prevalence, and the mean prevalence of pressure ulcers in Ireland is 15%. And it varies from 4% to 37%. So quite a variety in the figures. And the lowest prevalence was seen in the community setting, and the highest prevalence in spinal cord injury services. So in terms of looking at it from an older person, there's one study that notes that pressure ulcer prevalence in older persons is 9%. And from the acute care perspective, the findings suggest that prevalence rates vary from 12 to 18.8%. And as yet, we don't have published prevalence figures from paediatrics, from the hospice setting, or from obstetric services available to us from Ireland. But what you can see is that pressure ulcer prevalence is a snapshot of the problem. Basically what we do is go into a particular institution or go to a community care area, and we examine all of the patients that are under the care of the services there. We examine their skin and we say to ourselves, how many have a pressure ulcer and how many don't? And then we calculate the percentage as the number of people with the pressure ulcer divided by the number of people that we have assessed. Whereas incidence is slightly different in that what we do is we start off today, for example, and we might say, okay, let's go to one of the clinical care settings, and we will monitor all of the patients admitted into that setting and cared for within that setting over a period of time. And what we will do is we'll start off with the people who don't have a pressure ulcer, and then we'll count the number of people that develop a pressure ulcer while they are under our care. So there are 5 published studies that have reported pressure ulcer incidence in Ireland. The mean incidence is 10%, and it varies from 0.71% to 14.4%. One study has explored incidence from the older person services and reports an 11% incidence. The remaining studies are from the obstetrics, which is interesting because that's a new finding for us, and the acute care setting, and the figures vary from 0.71% in obstetrics to 14.4% in acute care. So once again, we don't have published incidence figures from paediatrics or the hospice services available from Ireland. So we can see that so far what we've identified is that yes, there is a problem of pressure ulcers. And so if we were to say that many of those could have potentially been prevented, then knowing that there is a problem is really important for us because it helps us to understand how can we put in strategies that are going to be able to reduce the burden of the problem. But of course, everybody that we take care of is a human, and all of us as humans suffer from the point of view of how this pressure ulcer specifically impacts on us as an individual. And so there are a number of studies that have explored this. And Essex showed us back in 2009 that pressure ulcers impact negatively on health-related quality of life, even after you adjust for other factors that may be influencing that. Like, for example, if somebody had congestive cardiac failure and a pressure ulcer, or they had diabetes and a pressure ulcer. So what it's showing us is that it has a significant impact. And Gorecki explored that a bit further and showed that all of the activities of daily living are affected. So it affects from a physical, social, psychological. The symptoms that the person has to experience seems to be a particular problem. There can be a financial impact for the person. And also there's a balance between the need to have specific treatments versus the effects of those treatments. And one such thing that was brought up was in terms of using, for example, alternating devices. So if the device is alternating and it inflates into the pressure ulcer and then deflates and then inflates into the pressure ulcer, that the very presence of the alternating surface may be impacting negatively on the person. Another thing as well was the realization from the individual with the pressure ulcer that it has an impact on the people around them and the people who care for them. So in the home environment, the members of the family, their carers, whoever, all have an impact. The pressure ulcer has an impact on them because they're the ones who maybe have to take on extra activities in order to be able to help that individual to recover from their problem. And Gorecki then further on in 2011 identified that the impact of the pressure ulcer is influenced by the individual's health behaviours. So depending on whether they have an internal locus of control about what they can do for themselves to get better, or an external locus of control where they are depending on healthcare professionals. And they also suggested that it's impacted, like the impact that the pressure ulcer has on me would be influenced by my experiences of the type of care that I have received, and also individual factors within myself, cognition, social support, and comorbidity. And I think that that's really important for us to remember because the experience that the patient has while in our care can fundamentally influence the impact that disease and disease processes have on their health-related quality of life. So what this particular slide is telling us is that it's important to be aware that pressure ulcers impact negatively on the person from a health-related quality of life, with all of the domains of the activities of daily living adversely affected. And I suppose worryingly, we can see from this particular study by Lozano et al. That in 2010 they looked at the global and regional mortality from 235 causes of death for 20 age groups in 1990 and 2010. And what they found was that there has been a 32.5% increase in deaths directly attributable to pressure ulcers. Now that's worrying for us because we need to say to ourselves, could some of these pressure ulcers have been avoided? And if that was the case, then there is an unnecessary death associated with healthcare provision that this person has experienced that they ought perhaps not have to have experienced. And it really helps us to place into focus the importance of pressure ulcers in terms of the whole preventative strategies that we're trying to achieve. Now, we don't have specific figures from Ireland in terms of the overall financial impact of pressure ulcers, but given the similarities between the Irish Healthcare Service and in some ways some of the UK health services, it's interesting just to take a look at this particular slide that's looking at the cost of pressure ulcers. And as you can see from the slide down here, that the expected cost of healing of a pressure ulcer by category will clearly increase as the pressure ulcer increases in severity. It's also looking over here that the mean time of pressure ulcer, to heal a pressure ulcer, is obviously going to be longer according to the severity of the pressure ulcer. And similarly, in the box down here on the right, the inpatient recovery time will increase significantly as the pressure ulcer increases in severity. So for us, what this means is that we really have to be able to have systems in place whereby we can really quickly recognise early stages of pressure ulcer damage so that we can avoid that volcanic eruption of stage 4. So the slide summarises that overall it's about $2 billion in cost to the UK healthcare system in aggregate. And the average cost to treat is about $10,000, whereas the average cost to prevent is $7,000. So it's highlighting to us that prevention is expensive, but it is not as expensive as treatment nationally. So from our own perspective, and even though all of us are not necessarily registered general nurses because we will have physiotherapists, occupational therapists, dietitians, etc., this is just an example of one of the codes of professional conduct. And of course, all of our bodies are regulated by professional codes of conduct. And if we take this a little bit further, and many of the standards that are within these types of codes of conduct will be similar across the disciplines. So it's saying that nurses and midwives, and we could argue that any healthcare professional, be that a physiotherapist, occupational therapist, dietitian, podiatrist, whoever, should use evidence-based knowledge and apply best standards in their work. It says that we should value research and that research is central to the nursing and midwifery professions because it informs standards of care and ensures that both professions provide the highest quality and most cost-effective services to society. And that might stand to reason to us when you think logically that anybody who is in our care deserves to expect that they are going to receive the highest standards of care possible, and that I, as a practicing healthcare professional, endeavour in every intervention to deliver high standards of care. If we look at the values for nursing and midwifery which were launched, we can back in 2016, we can look at things like the values were really important because they explore 3 core values of compassion, care and commitment. And what might that mean for us? Because it's saying that compassion means that we show empathy and respect for the person to ensure that their dignity is upheld at all times. And that's something that we could reflect on in the delivery of care, because we say that the nurse and midwife and any healthcare professional upholds the trust of the person by providing care that really, at its most fundamental, is based on principles of genuineness, kindness, comfort and presence. And you know, if we thought about our interactions with people and if we try to keep that core value of compassion no matter what our health professional background is, if you were the person who was in the bed receiving the care, or you were the person in the community receiving the care, it would be an amazing experience for you if that care that you received was, you know, sort of like espoused in a value of compassion. And then care means that as a healthcare professional that I have the required knowledge, skill and competence to connect with the person that I'm taking care of by genuinely listening to and communicating with the person. And that I can demonstrate safe, evidence-based and collaborative practice. And that's what this whole Pressure Ulcer to Zero campaign is about. It's about having the person in the centre focus by providing evidence-based interventions which enable a reduction in pressure ulcers, but that we're working collaboratively within the teams that we find ourselves in, and of course the patient is at the centre of that collaborative team. And then commitment means that we have a person-centred approach to our professional practice. And that really means that we have the professional courage and commitment to lifelong learning. And that's demonstrated by an intellectual engagement. And all of you espouse these values every single day by virtue of the fact that you have decided that, yes, pressure ulcers are important, and that you feel that you can make a direct contribution to the quality of life of the people that you take care of by being a part of this Pressure Ulcer to Zero campaign, and by living the espoused values of compassion, care and commitment. And it doesn't matter whether you're a nurse or a midwife, or whether you're a healthcare professional, or you're a healthcare assistant. It doesn't matter who you are. You, by delivering care in this ethos, will be ensuring that the person is always at the centre of what we're doing, and we always have their best intention at heart. So the Nursing and Midwifery Division, working with the Quality Improvement Division, are developing performance indicators, of which pressure ulcer incidence is one. We know from HICWA, and many of you can sing this to me, that a pressure ulcer of grade 2 or above is considered to be a reportable event to them. And also now from the Health Service Executive, we have the series reportable events, and that includes a stage 3 or 4 pressure ulcer, which is acquired after admission to the health and social care facility. So from all of the angles, from the angle of the fact that pressure ulcers are common and many can be prevented, that they impact negatively on the patient's health-related quality of life, that all of us espouse the core values of care, compassion and commitment, and that there are regulatory requirements around all of us, no matter who we are, because we choose to work in the health service, that demand of us a measurement, attention to detail when it comes to preventing pressure ulcers and reporting those that do occur. And I suppose from a patient safety perspective, the challenge is that 1 in every 10 patients is harmed while they receive hospital care. And you would like to think that that could be reduced or that would not happen. And when we had the report of the series reportable events that was published in September 2015, just from the point of view of pressure ulcers, that 20 or 19% of the 103 care management issues reported related to a category 4-1 within the series reportable events, which is a stage 3 or stage 4 pressure ulcer. Now, challengingly and worryingly, in 3 cases, it was confirmed that the person had died as a direct result of the pressure ulcer. And that's something for us to reflect on and just to ask ourselves every day when we're in care, delivering care to people, are we sure that we have done the best that we can given the resources available to us? And are we sure that we're always striving forward to increase our preventative strategies, to ensure that we're competent to do what we're doing, and also that we're keeping the person as our centre focus? Because at the end of the day, for each and every one of us, it's important to remember that my life is in your hands. And that's what the patients maybe not always say to us because they may not be able to articulate it. But that's what they mean when they place themselves into our care, that their lives is in our hands. Okay, so if we move on, then in part B, what I'd like to talk about is what causes pressure ulcers, which we've already alluded to very slightly, but let's take this in further detail. Talk about the effects of pressure and shear. Then talk about how we might select risk factors. And then look about risk assessment itself as a whole phenomena. And then ask ourselves, maybe there's an alternate method that we could use. And then what would be the take-home message for you? So remember we said that a pressure ulcer is localized injury to the skin and or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. So what is pressure? Then pressure occurs when bony prominences squeeze and stretch the surrounding soft tissues, and it deforms the tissue. So imagine if you had a balloon and I sat on the balloon, well, what would happen is that that balloon would squash and it would change its shape. Now, gradually, if I continue to sit on the balloon, eventually it would burst altogether. The thing about pressure, though, is that pressure is equal to force divided by area. Now, why that's important for you is that it means that for patients within your care, that pressure will not be evenly distributed over all areas of the body. So therefore, you have to watch out for areas where these areas are smaller, because the same force applied to my elbow as opposed to my sacrum or to my heels, because my sacrum is larger than my heels, if you apply the same force, the pressure will be greater because the area is smaller. So it's worthy of thinking about, because as you place somebody into bed, the heels could be much more problematic for you than maybe other areas of the body. So then let's say, what is shear? So shear is said to occur when the skin stays in one place while the bony structures move forward, causing a stretch deformation of the soft tissues. So think about somebody that you might place sitting up in bed, nice and lovely, and then they start to slide down the bed. And as they're sliding, the skin stays in one area, but the bones are moving forward, and that's causing a stretching of the tissues. Now, if you just want to think to yourself about what actually is pressure and shear, if you place your hands together and you press on them, remember Newton's law that for every action there's an equal and opposite reaction. So as you're pressing one hand against the other, there's pressure from the other hand moving back. So you get pressure both from the outside as well as from the inside, okay? And then shear would happen as you're moving your hands across each other. You're getting shear forces there, but there wouldn't necessarily be an awful lot of tissue movement as opposed to if I was moving it across the top of my hand rather than the base of my hand. But if you just kind of start doing that yourself at home, you start to see what do you actually mean by pressure and shear. And you can see when you press your hands together that there's always going to be a force coming from the bottom up, just as much as a force coming from the top down. So pressure and shear affect three functional units in the body. They affect the capillaries, the interstitial spaces, and the cells themselves. And they do it through four different mechanisms. They do it through local ischemia, so if you occlude the blood supply, you've no blood supply. If you restore the blood supply to a previously devoid area, there is a risk of getting a reperfusion injury, whereby you get an influx of oxygen-derived free radicals, which the body's own scavenging mechanism can't handle. But that will be majorly influenced by the length of time that somebody has no perfusion to the area. You know that the cells and the interstitial fluid all work in tandem together. So anything that distorts or squashes the cells or the blood supply is going to squash your lymphatic flow as well. So it makes sense to us to think that if you're occluding my blood supply, you're also occluding the interstitial fluid flow. And then we've mentioned sustained cell deformity, and that's the major place of focus for us in terms of thinking about pressure ulcers, because too often we're thinking about them as being something that starts at the superficial layers of the tissues, when in fact the majority of pressure ulcers may in fact occur from the bottom and emerge outwards. Because when muscle cells are under pressure, their metabolism changes immediately to an anaerobic state. And cells, when they're under pressure, are destroyed by two main mechanisms. The waste products suffocate the cells, and then cell deformation changes the osmotic process. And death can occur really, really quickly, as quickly as between 2 and 4 hours. Now, the cell deformation can be really extreme. And when the cells are stretched around the bony tuberosities, you get shear strain. And you get changes in the cell membrane and nucleus membrane. And when that occur, it can lead to permanent destruction of the muscle cell. So if it's destroyed, it's totally damaged. And that results in deep damage within the tissues. Now, cells are able to tolerate strains for up to 1 hour, but gradually reduce their tolerance up, at about 3 hours, after which cell death is evident. And then, as you know yourself, when you have cell death, you deprive the area of oxygen and nutrient supply, and also deprive the area of the removal of waste products. So after all of this, you get a massive inflammatory response. So it's a bit like a catch-22. Because we damaged, then there's an inflammatory response. Because of the inflammatory response, there's an influx of a lot of cells, and that in itself can cause further occlusion of blood supply. So it's quite a problematic process. Now, the key for us, though, in practice, is that it is important to be aware that even if a wound is not visible on the surface, it doesn't mean that it's not present. Because if we think about the deeper layers of the tissues being affected, and as a muscle is much more susceptible to changes in perfusion than is the skin, then it makes sense to us that the damage may well start at the lower levels. And when people who can feel pain complain about pain, although nothing is seen at the surface, it might suggest to you that damage exists internally. And in those who can't feel, the worry is that undetected ulcers can start in the deeper layers and progress into ulcers with varying amounts of tissue destruction, depending. So the trick for us, or the key for us, or the challenge for us, is that can we start to recognise this damage really early before it ever becomes visible on the surface of the skin? Now therein would be the $60 million question. So as I said to you already, the problem is that pressure ulcers in the, let's call it the good old days, the classification has its origin in the classification of burn injuries, assuming that Zena is an awful Aegis, she goes out into the sun, she's really fair-skinned, she wears no sunscreen, and the sun will burn me from the outside and burns my skin, and the longer Zena is an Aegis and stays lying out in the sun, the deeper the damage is actually going to be coming from the outside inwards. But we know that that's not the case for pressure ulcers, because the majority of pressure ulcers develop from the inside out, as you can see, starting off at that bone-muscle interface emerging outwards. As is the case, this is the end result or the manifestation of all of that. So when we're thinking about risk assessment, like what you're actually really doing is you're measuring risk. And you want to use that measurement to determine your priorities for care. So you want to say, Zena's at risk for these very reasons, and therefore I'm going to put in a care plan which is going to try to help to alter this risk that Zena presents. So what is a risk factor then? It's an attribute, characteristic, or exposure of a person that increases the likelihood of them developing a disease or injury. So which risk factor? So if I said to you, is age a risk factor? You're all going, nod, yes, Zena, age is a risk factor. But the worry is, right, is that if you're saying that age is a risk factor, now as far as I'm concerned, the closer I get to it, though I'm not there yet, is that 65 I would consider to be very young. So, but anyway, if you look at the figures here, look at the jump from 1991 to 2031, we go from 403,000 to 991,000 of people aged 65 years and plus. So if you're saying, oh, straight away, age is a risk factor for pressure ulcers, then you're going to have a care plan for pressure ulcer prevention for all 991,000 of people aged 65 years and older. And of course you're saying to yourself, don't be silly, Zena, they're not all at risk. But if we use the classification of age as being a risk factor, Then, are we going back to age exposing me to pressure and shear? Does it automatically, straight away, do that? And the worrying thing as well is that if we look at healthy life years, in all of the 25 EU countries, men aged 50 could expect to live a further 17.3 years, i.e. 60% of the remaining life free of activity limitations. Whereas the number of healthy life years at 50 for women was 18.1. 54% of the remaining life free of activity limitations. So the concern is that, okay, getting old is a fantastic thing, but what we're looking for is active and healthy aging. But when we're talking about pressure ulcer prevention, if we use age as a primary risk factor for pressure ulcer development, then you will have to put a prevention care plan in for everybody aged 65 years plus. Whereas clearly, not everybody who is old is at risk of pressure ulcers because they have not been exposed to the primary cause of pressure ulcers, which is pressure and shear. I hope that makes sense to you. And similarly, we will look at malnutrition. And of course, you know that the food pyramid has changed, and you can see at the bottom now, we have our fruits and vegetables, whereas this whole wheats and cereals, etc., has moved up a level. But all of you will say, yes, 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 malnutrition is a primary risk factor for pressure ulcer development. But if we look, like this person is clearly malnourished, but as long as she stays up on her Louboutin and they fit properly, this person will not be at risk of pressure ulcers because she does not have exposure to the primary causative factors, which are pressure and shear. Incontinence, we could say the same thing, but 37% of the global female population suffer with some form of urinary incontinence. So that means that if you're saying that incontinence is a primary risk factor for pressure ulcer development, then 37% of the women in this picture, you're going to have a prevention care plan in place for. And of course, are they exposed to the primary causative factors for pressure ulcer development, which is pressure and shear? And clearly, they're not. And if you look at the risk assessment tools, there are many of them. There are over 90, which really needs to put a little warning bell above your head saying, why can there be 90 risk assessment tools all focused on the same thing? So we just take these four, Norton, Braden, Waterloo and Mailer. And although they share many of the same risk factors, they don't share them all. And that in itself, you have to ask the questions because, you know, we would adopt Braden maybe and use Braden for every single person in our organisation. And the question really is, how well are they related to pressure ulcer development? So take the assessment tools here on your left-hand side, including clinical judgment. Now, the sensitivity of the instrument is the ability for it to truly detect those who are at risk. So if we say, you're at risk according to Braden, then you definitely are at risk. But can you see the figures there? We've got 57.1%. That means that only 57% of the time are we correct. The rest of the time we're not. 46.8% of the time with Norton. 82% with Waterloo. Pretty good. And 50% with clinical judgment. So half the time we're not right. Specificity is the true negative. That means that if you say I'm not at risk, I actually am not at risk. And once again, you can see the figures vary enormously. But Waterloo is down as far as 27.4%. And the odds ratio is the odds of risk prediction. So if I say you are at risk in Braden, what's the odds that you actually are? So Braden you'd be 4 times more likely to develop a pressure ulcer with Braden. If I say you are at risk in Braden, you're 4 times more likely. 2 times with Norton, 2 times with Waterloo, and 1.69 times with clinical judgment. So what it's showing you is that there's great variability in them, and not any one of them is 100% sensitive and specific. So you have to exert caution, and even with our own clinical judgment, we're not always going to be right. So we are really trying to strive for more objective means and methods which would enable us to recognise the problem. So take an example here. So this little lady has been risk assessed using Braden and has been identified to be at moderate risk of developing a pressure ulcer. Whereas this little chap has been assessed using the exact same risk assessment tool and has been identified to be at low risk. But who is actually at risk? Because remember we said it is the exposure to something that predisposes them to developing a pressure ulcer. So is my granny exposed to pressure and shear at that moment? Clearly she's not. Whereas this young chap is, because he is seated in a wheelchair where the weight-bearing areas are his ischial tuberosities, which are relatively small compared to the load which is being placed upon them. So do you see how important it is for us to focus the risk in relation to the causative factors? And here's another one where both of these people are assessed using Braden, okay? And both of them have been assessed as being mild risk. Whereas when we look at mobility assessment, so this person here in red makes 0.2 movements per minute per night. And this person up here makes 8.2 movements per minute per night. Hey-ho and presto, this patient here develops a pressure ulcer, and this patient here doesn't. But both of these patients have been placed in the same category. But clearly, the macroscopic way in which we are assessing mobility is not serving these people well, because these people are making varying amounts of mobility movement themselves, and this lady is hardly moving at all. And that's the reason why we need to be cautious, because clearly, because this person down here is being exposed to pressure and shear, then there's a major problem. And furthermore, when we look at a cohort of patients monitored using Waterloo over a 4-week period, the means and standard deviations for the Waterloo scores didn't change at all. So that would mean for you that nothing was changing with your person, with your patient. But clearly nobody remains exactly the same over a 4-week period, and it's the same for Braden. So all of this just raises questions for us, that are we sure the instruments are reflecting exactly what we want them to reflect, i.e. the risk or not of developing that a pressure ulcer is caused by pressure or pressure in combination with shear. So we need to know which patients are exposed to that. There is a hierarchy of risk factors. Pressure and shear are the prime causes of pressure ulcers. Immobility is the factor that exposes me to it. Then, in the presence of immobility, certainly and absolutely factors around age, incontinence, malnutrition, general health, and even environmental factors like lack of staff, etc., are going to influence my tolerance to pressure and shear. So if I am older and I have problems with perfusion, then in the presence of immobility, I might develop a problem much more quickly than somebody who doesn't have that problem with perfusion. Incontinence causes damage, as we know, so a lot of incontinence-associated dermatitis, big problem for patients, and in the presence of that, my skin, my tissue is already damaged, so I cannot tolerate pressure and shear in the same way as I might if I didn't having continence-associated problems. And the same with malnutrition, etc., etc. And I hope this is clear for you. So for you, you should use a structured approach to risk assessment that is refined through clinical judgment. So you're using both of them. And it is informed by knowledge of relevant risk factors, as we have gone through. So think about your hierarchy. Your structured approach should include an assessment of activity and mobility and skin status. So clearly you need to look at the patient's skin and you need to monitor carefully their activity and mobility. But you shouldn't rely on the results of a risk assessment tool alone when assessing an individual's pressure ulcer risk. Because take the case of those two people we presented, the older person and the young chap in a wheelchair. If you were just blindly accepting what Braden had said in those cases, you will have missed the person who is most at risk of developing a pressure ulcer. So focus on the reasons why the person is getting the score, not on the score itself. So bringing it all together for you. Pressure ulcers are caused by pressure and shear. Factors within the individual will increase the likelihood that somebody is exposed to it, i.e. immobile, and then once exposed to it, other factors, age, malnutrition, etc., influence the time that that person can tolerate the immobility. And then there is the environmental factors, whereby somebody is waving at us at risk of pressure ulcers because they are immobile, and we either don't provide them with preventative strategies that are appropriate, or we can't access preventative strategies that are appropriate, or we can't afford them. Then there are environmental factors which are important for us to consider as well, because they will influence the likelihood that the person is going to develop a pressure ulcer or not. So thank you very much for listening.